Hey guys, Alicia and Ashley again with some more head anatomy for you. We really want to encourage you to watch both videos because, as I'm sure you've already figured out, Ashley did one half of the checklist and I'm going to do the other half today. So please look at both of them to get a more comprehensive review of all the structures you need to know for the practical. As always, if there's anything that we left out, please grab us during an open lab or whenever so we can answer questions for you or clarify something. We're going to try and be as comprehensive as possible, but inevitably we will forget something or have destroyed a structure. So, as always, we hope this really helps. Thank you guys for watching. Let's get started. The first section that I would like to cover is the posterior pharynx. And there's some things that I want to point out right away because this area can be one of the more tricky areas on the practical just because of the view that we now have that's kind of backwards from how we've been looking at everything up to this point. I kind of put it together like this so that you can see some of the structures and landmarks as they would be before we bisected. But keep in mind that in a practical situation, since we've already bisected like this, you're going to have the split head view where everything's a little bit more distorted and not really how you're used to looking at it. So before you take the practical, I would spend some time practicing seeing everything more of the way you dissected it before we bisected and run through all the structures like that, and then pull the heads apart, make it a little bit harder for yourself, and do it all over again. So the first thing that I want to point out is this. Let's identify that. So I'm sure you guys can tell this is the greater horn of the hyoid bone. This is one of the more prominent things that you will see with this posterior to anterior view of the pharynx. I will tell you that this one does stick out quite a bit. Not all of them protrude like this, so you may have to go searching. But this is one of the most important landmarks when you're in this area because especially of muscle attachment. So let's move on to this structure here. Could be pinned, could have a string wrapped around it. For time's sake, I'm just going to grab it with my forceps here. So this is actually inferior pharyngeal constrictor. Might be a little confusing. It's slightly in a different location on this specimen, and I'll explain why. So inferior constrictor the fibers should run down inferiorly and attach on that oblique line of the thyroid cartilage. You can kind of see that here. So that's how I know for sure that I'm looking at inferior constrictor, because it comes down to the thyroid cartilage. However, these fibers are pretty close to what I just showed you as the greater horn of the hyoid. You can see them right here. That's pretty close to the greater horn of the hyoid. However, you know that the greater horn of the hyoid is more closely associated with middle constrictor. And that's what we see here. See that clear separation and the clear separation here? So from here to here is middle constrictor. And they should, all of these fibers, as I discussed in my lecture, should be wrapping on that inside of the hyoid bone. So in a lot of the other cadavers, you'll see this greater horn of the hyoid pretty much right at the level of the middle part of the middle constrictor, which is again from here to here. So I would, number one, look for this, and then number two, try and find the demarcation between the fibers. That will really help you decide where you are. Let's identify up there. So this is our superior pharyngeal constrictor. You can clearly see the separation of fiber direction right here. These superior constrictor fibers seem to run a little bit more horizontal, whereas the middle fibers are more obliquely oriented or triangular. Keep in mind too the function of all these constrictors. They all aid in swallowing to constrict that tube of the pharynx, and they're all innervated by cranial nerve 10 via its pharyngeal branch. So let's move on. I'm going to kind of separate the heads and we'll get into some of the deeper structures in the back of the pharynx here. Let's start with a bigger structure that you can see right away. Just identify. So this is where the orientation can sometimes mess you up or trick you a little bit. Because we're looking from posterior to anterior now, this is internal carotid artery. So remember that from the anterior neck, we saw external carotid artery first, which is laying right here, and then internal carotid artery was a little bit more posterior. Now that we're looking the opposite direction, internal carotid is going to pop out first. One more landmark that I did want to point out that I forgot to mention is this bump here that we see. It's covered in some muscle and fascia, but just as a landmark, if I tagged it like that, you guys should still be able to tell what this bump is coming from. So this is the superior horn of the thyroid cartilage. And this can also be a really, really helpful landmark when you're looking at the pharyngeal constrictors or just the posterior pharynx in general. However, sometimes the greater horn of the hyoid and the superior horn of the thyroid cartilage are a lot closer. You'll see them almost right next to each other like this in some cadavers. But in this specimen, they're a little bit farther apart and you can see them really nice. But make sure you use these two big landmarks when you're back here to help you. Okay. Let's go for this structure right here. What's overlying my probe? Just identify. So this could be a little tricky, but use your landmarks again that we just talked about. So hyoid bone, thyroid cartilage. That should immediately make you think of some structure with things piercing or passing through it. The thyrohyoid membrane lays right here. I know you can't see it, but you may not be able to see it in a practical situation. However, because of these two landmarks and because you know there are certain things that pierce through it, this is a fair tag. This is the internal branch of the superior laryngeal nerve, or internal laryngeal nerve is fair as well. So because I know I'm in between thyroid cartilage, hyoid bone, and here underneath here is my thyrohyoid membrane, I know that this is my internal branch of superior laryngeal nerve. And you can follow it all the way up, coming back into its parent structure, which is, let's identify. Maybe that helps. So this is the vagus nerve, cranial nerve 10. It's pretty awesome that we can actually follow this all the way up to where it comes off the vagus. We couldn't really see that in the anterior neck, but now we can. So if I tagged it here, I would still call this the vagus, but I could also grab it up here and show you everything together. So to be consistent, we follow the structure down with our eyes. This is where we just tagged it, going through the thyrohyoid membrane. And now we see, sorry, give me a second. We see this coming off. So this is the external branch of the superior laryngeal nerve. I know it has a little connection right there. That's probably a little anomalous sympathetic connection, but if we follow this all the way down, we can see it coming past our thyrohyoid membrane, all the way down into that space in between inferior constrictor, and eventually, if we opened it up enough, we would see cricothyroid muscle. That's how we know that this is the external branch of superior laryngeal nerve. And you may not be able to see cricothyroid muscle or half of this opened up on the practical, but because you can follow it back to the internal branch and then keep following that back to the vagus, you know that those are the only two branches that come off the superior laryngeal nerve. External branch of superior laryngeal nerve. Let's go for this next. So this is our pharyngeal venous plexus. I know there's a lot of nerve-like looking things back here, but the biggest tip off is that you can see it kind of spreads out everywhere and it looks completely see-through and flattened. That's the best clue that we're talking about a vein. You can even almost see some little red purpley marks inside there. That's the best clue that we're looking at veins here. And you know that the pharyngeal plexus of veins just spreads out all across the posterior part of these constrictors. We had to remove a lot of them with the fascia that we took off to even be able to see the muscles. So there probably won't be that many left, but here are some, and they're on your list, so I wanted to make sure I went over them. Next, let's tag this. Sorry, let me get a better pin in it. Okay, just identify. So this is our superior cervical sympathetic ganglion. Probably one of the most prominent structures you'll see in this upper posterior pharynx. You can see it's just kind of a massive dilation with some nerves coming out, the inferior aspect of it, that you can follow all the way down into the neck. That's one of the biggest clues that you're looking at part of the sympathetic chain. And then as you move up, you see this big dilation. Gotta be the superior cervical ganglion. They could take that question a step further and ask about cell bodies or what resides here. So make sure you guys study that really well as far as autonomics go. Autonomics are going to be pretty important for this practical. And so what would be living here, or what cell bodies would be residing here? So we would say postganglionic sympathetic fibers or cell bodies, because the sympathetics come up from T1 to T4, ascend in the chain, synapse here, and then the postganglionic fibers, sympathetic specifically, disperse to the head after that. Moving on. Let's identify this structure. So this is our hypoglossal nerve, or cranial nerve 12. Make sure again to write your Roman numerals on the practical. I could have given you a better view of it here, so now you can see the whole path of it, but the biggest clue that will always tip you off every single time is that it's the only one of these big cranial nerves in the posterior pharynx that doesn't just go all the way down, it dives towards the mouth, back around all of these structures here that we know. So remember, from the anterior view of the neck, we could see it diving again into the mouth, but it laid on top of everything. In this view, from posterior to anterior now, it dives underneath everything, but still clearly has that path where it comes down and then almost goes perpendicular straight towards the mouth. That's your biggest clue. We also see another structure very closely associated with it that you can use to help you figure out what you're looking at, which is this right here. And if I was really nice, I would pull this out of the way too, but you may not get that, so I'll leave it like this. This is our occipital artery. So there's a lot of stuff in the way here, but we can clearly follow it back and see it coming off of external carotid artery right there. External carotid, occipital artery coming off posteriorly and heading straight up to the occipital bone, right where our hypoglossal nerve crossed over towards the mouth. So that relationship will come back to haunt you guys right here in the posterior pharynx. You should definitely remember this one. Let's identify this structure next. So this is our ascending pharyngeal artery. This is that nice little elusive artery that we had so much trouble finding in the anterior neck. Well, now we see a wonderful view of it because it comes off of the external carotid, which is right here, posteriorly, and goes straight up. So this is where we really see a really good view of our ascending pharyngeal artery. Along the way, I have cut one here, but you may see little branches coming off of it, diving into the pharyngeal constrictor muscles. This would just be a pharyngeal branch of the ascending pharyngeal artery. Let's move on to one of the very high yield structures in this area. So I'm going to leave my probe there, but I'm going to grab what I want to tag right here. So this is cranial nerve 9 or glossopharyngeal nerve. And the reason why you know that is because I'm tenting up this muscle right underneath it. These two structures run right together through which gap to enter the pharynx? That's right, Ashley, that would be gap 2. So these two structures enter gap 2 to gain access to the pharynx between superior constrictor and middle constrictor, right there. So glossopharyngeal or cranial nerve 9, making this muscle underneath it, everybody knows, stylopharyngeus. Very good. Keep in mind, and we'll show again later on, that you can see both of these structures in two different views, right here where I've just shown you, and inside the pharynx, which we'll get to when we get to that section. One other thing that I wanted to point out, we see all these nerves coming out here. There's tons of branches, all looking like they're heading out to the constrictors. That's because we have a beautiful pharyngeal plexus of nerves that lays all on top of here. A lot of the branches got cut off when we were taking the fascia off of the constrictors, but here we can see some branching out underneath the plexus of veins to get to the constrictors. I would have to show you a really good view of where these are coming from in order to fairly ask you what it is, but here you can see that all the way at the top if I tag it there. you guys would identify this as so this is the pharyngeal branch of the vagus nerve. And I know that can be tricky, but I know that because underneath my superior cervical ganglion, I have the main vagus nerve. And I can clearly see these guys that I was just tagging hopping right into that main stalk of the vagus. The other nerves that participate in the pharyngeal plexus come from glossopharyngeal that we just talked about, and we can see little branches coming off of it right here, going towards the constrictors. So this I could tag also as the pharyngeal branch of glossopharyngeal going to the plexus. You also have sympathetics going into that pharyngeal plexus to balance out the parasympathetics. So if I go back to our superior cervical ganglion, you can see our sympathetic chain going all the way down into the neck, and here are all these lovely branches that are going straight out into the plexus, some continuing to go down. In reality, this is just a net of nerves crossing over here, but these were the few that I could keep intact. So they also participate in the pharyngeal plexus. Just to be complete, let's identify this structure here. This is our internal jugular vein. Poor thing's still sticking around, so it is possible to see this back here as well. And let's identify this as well. So this is our superior thyroid artery. We saw it really well from the anterior aspect of the neck, but now we can see it again. The first branch off of external carotid, which is right here, diving down towards the thyroid. And you can follow it all the way down. So don't forget about that guy. And there's another big arterial branch that you might see right here. Let's identify that. This should be our lingual artery. Might be a little tricky because with everything that's sitting in here, you may not be able to see all the branches like you would want to, but you know that it's the very next branch that we should see because we just saw superior thyroid, we saw ascending pharyngeal. This is the next one that we should see. So for convention's sake, learning them in the order that we do, I would say this is lingual artery. Okay guys, let's identify this. So this is one of the last nerves, big nerves that we see in the posterior pharynx. You can clearly see it's running out to this muscle, kind of hanging out here laterally. That should immediately tip you off to think that this is spinal accessory or cranial nerve 11, clearly going to what's left of our sternocleidomastoid muscle hanging off here. Whenever you're looking at any of these nerves that we talked about in this posterior pharynx, it's a really good idea to think about second order questions that could be possible. And one of the best ones that I can think of is what components or nerve components are lying in this structure or running in this structure. And for this, it would just be general sensory efferent or GSE, because spinal accessory provides motor innervation to sternocleidomastoid, and it's not an arch muscle, therefore it's just GSE. So I would urge you guys to consider all of those second order questions for pretty much any nerve that we just discussed in here. If you need help with that, definitely come find Ashley and Alicia, or myself and Ashley in open lab, or ask Dr. Funk or anybody. Okay guys, now we're gonna move on to the nasal cavity. I'm gonna save the pterygopalatine fossa for last because there's a lot in a small little area. But I'd like to cover first is the nasal cavity with all the sinuses and everything. So let's start with that. First, let's just identify. All right, so this is the inferior nasal concha. And you should be able to tell that it's still covered in mucosa. There's a little bit ripped off here, but this is what it looks like still covered with mucosa. So this is the inferior one, the nice big one. This is our middle concha. You can see the mucosa is removed right here, so I'm actually tapping on bone. And then up in here is our superior concha. They can be really different in size from cadaver to cadaver, so this is one of those structures that I would really recommend you guys get a good look at from body to body because they can be pretty variable in the way they look. Okay guys, let's identify this structure, what the wire is going through. So this is our nasolacrimal duct, and this is a really common way for us to tag something on the practical, especially if it's like a duct or a canal, is to put one of these wires through. And this is how in lab we wanted to discover a lot of these canals and hiatuses, was by using these wires. So it's pretty common that we would tag it something like this. So you can clearly see that the wire is going up through the duct here. So this is how the tears from our eyes get down into our nose, nasolacrimal duct. And you can see that in order to see this, I've had to fracture and reflect my inferior concha. So the nasolacrimal duct comes out from underneath the inferior nasal concha. Moving on. Let's identify this. So this is the opening to the maxillary sinus. And this one should be probably one of the easier ones to tell, mostly because we have this giant hole in our maxillary sinus here, and you can clearly see the wire going through it. But if you didn't have the big hole there and you couldn't see the wire in the maxillary sinus, you would still know that it's the opening to the maxillary sinus, because you can see this big hole on this structure here. Let's identify this, what my probe is sitting in. This is the semilunar hiatus. So this is a pretty good example of one because it really does look like a half moon kind of. It looks like a semilunar structure. And hiatus because it's got all these little openings in it. There's another structure in the middle of this semilunar hiatus. Let's identify this. This might be how you would see it tagged. So this is the bulla ethmoidalis. Literally just means kind of mound. Ethmoidalis because there's a structure running through the middle of it that has to deal with the ethmoid sinuses. So if I asked to identify this, you would say, so this is the opening to the middle ethmoidal air cells. So I always like to think on the middle of the bulla ethmoidalis, right in the middle of it, is the opening to the middle ethmoidal air cells. That kind of makes sense to me. Then I think of this bulla as kind of like an anthill, if you will, with the hole in the middle being the opening to the middle ethmoidal air cells. Around the anthill, you have like a moat, and that's the semilunar hiatus. Now, there's quite a few things in this moat. One of them we already talked about, the opening to the maxillary sinus, which you can clearly see, a nice big hole there. Okay guys, let's identify this. So this is the opening to the frontal sinus through the semilunar hiatus, and you'll notice the wire is passing through the most anterior part of the semilunar hiatus that you can see. So the most anterior opening on the semilunar hiatus connects to the frontal sinus, which you can see out here. This is also part of it over here. It's called the frontonasal duct. So this would be a really great way that we could tag it. You may not get a perfect communication with the wire coming out in here, and a lot of times the frontal bones on the cadavers have been kind of destroyed from our other dissections. But this is a way that we could tag it, or we could pull this all the way through here. You may not be able to see it, but you would see the wire just barely going into the very most anterior portion of the semilunar hiatus. Either would be fair. Next one. Which I may or may not be able to find. Just next to the connection to the frontal sinus is our opening to the anterior ethmoidal air cells. That one's probably going to be a little bit harder to identify, but again, if somehow we were able to get a wire through here, if it was connecting with the anterior ethmoidal air cells, you might see it pop out up in here. I can actually see a remnant of the air cell right there and there. So really look if there's a wire in this area, look and see if you can see where it's coming out. And if you can, then that will be your biggest clue as to what we're trying to talk about. Is it coming out in the frontal sinus, or is it coming out more where the ethmoidal air cells belong? The last connection to the ethmoidal air cells is via the superior concha. From underneath the superior concha is the opening to the posterior ethmoidal air cells, which we can see right here. The posterior ethmoidal air cells were a little bit destroyed in this dissection, but that's exactly how they would pop through or communicate through. So again, this was our superior concha here. A little bit small in this cadaver, but just be aware that all three can be a variable size. And then there's another big sinus in the nasal cavity here. We had to dissect through a lot of them for other dissections, but this is our sphenoid sinus right here. The bone would be enclosing this whole area right here, but like I said, we had to destroy part of it for some of the dissections. So just be aware your sphenoid sinus sits right in here, and it has an opening, it has another communication, would kind of be sitting right like this. So if you can imagine a hole or opening kind of right here where that red mark is on the wire, that's where the opening would be, and it would be connecting the sphenoid sinus to the sphenoethmoidal recess. So if you imagine the sphenoid bone, or the sphenoid sinus being fully enclosed here by bone, there would be a little space between the bone and the superior concha. That would be the sphenoethmoidal recess. Okay, let's move on down. Let's just identify this structure. And let's be specific. So this is the cartilaginous portion of the auditory tube that directly communicates with the nasopharynx. Some of you might be wondering why I said it's the cartilaginous portion of the auditory tube. That is because the mucosa has been removed. This is one of those situations where you'll really want to get in close and take a really good look at whether the mucosa is intact or it's not. If the mucosa had still been intact, it would look more like this over here. But here you can see how it's more pale looking, almost a little white, and if you could touch it, you would feel that it's much harder than just mucosa feels. So really take a good look, because some of the cadavers on one side would have the mucosa removed, but the other side the mucosa might be there. And if the mucosa is present, and I have the pin in the exact same place, you guys are going to say that it's the torus tubarius. Exactly. So now let's identify this structure. This is the levator veli palatini muscle. Hopefully the video can show you guys, or the camera can show how nice these fibers are, coming straight down to insert on the soft palate. Another great second order question would be action of this muscle, so definitely study your actions for all of these muscles here in the pharynx. Okay, let's identify innervation. So this is tensor veli palatini, just medial to the muscle we just identified, levator veli palatini. Both of these structures are innervated by cranial nerve 5, V3 branch specifically. So that's a really great example of how action or innervation could be asked as a second order question with these little muscles. So definitely review them. Okay guys, let's identify. So this is salpingopharyngeus muscle. Muscle because you can see the really nice little fibers. I know it's tiny, but get in there really close and check for fibers. If I just wanted you to identify it as the fold, then I would have made it, it would look more like this. The mucosa would be on top of it, and see how down here there's mucosa overlying. That's what it would look like, versus up here you can really see the little fibers coming all the way down to blend in with the rest of the pharynx. Moving on. Let's identify this muscle. So here we have palatopharyngeus muscle. Again, get in here really close, look and see if we have mucosa on top of it, like you can see over here. No, the mucosa has been removed. I see nice, distinct, like dark red muscle fibers sweeping down into the pharynx. Could again ask action of any of these little muscles. So remember that palatopharyngeus aids in swallowing and also elevating the thyroid cartilage up during swallowing. Just identify. So this is palatoglossus. Think about what it's attaching to, from the soft palate with the nice uvula as a landmark to the tongue, and I can see clear muscle fibers, no mucosa on top of it, so it's just palatoglossus muscle. Let's identify. So this is glossopharyngeal or cranial nerve 9. The big clue is that it's coming through the pharynx here to gain access to the tongue. We know that glossopharyngeal is responsible for taste and general sensation to that posterior 2/3 of the tongue. I'm sorry, posterior 1/3 of the tongue. That's probably this area right here, with this area being the anterior 2/3. So it's going right to that area, posterior 1/3 of the tongue. This would be a really great time to ask a component question. So, like I just said, we're providing taste to this portion of the tongue as well as general sensation. So remember your components, and then there's a nice structure running right with it. Let's identify what pharyngeal gap this structure is going through. I'm sure you guys all got it by now. This is gap 2, and the structure is stylopharyngeus muscle. So these two guys, glossopharyngeal and stylopharyngeus muscle, both enter the pharynx through superior constrictor and middle constrictor to gain access through gap 2. So remember, we talked about stylopharyngeus on the posterior pharynx back here. You can see a little bit of it coming through right here, as well as cranial nerve 9 right there with it. So there's two different places that we could ask either of those structures. Okay guys, just identify on this one. So this is the opening to the auditory tube or eustachian tube. This is likely how we're going to tag it, with a wire going through or something going through it, so that you know that we're talking about a tube or a canal. And we can see that the wire is going underneath torus tubarius, or at this point the cartilaginous portion of the auditory tube. So automatically you should think that we're talking about the opening to the auditory tube. What if I tag that space? What would you guys think? So in this case, I would be talking about the pharyngeal recess. The only tricky part here is that there could be a tonsil, pharyngeal tonsil, sitting right up in here. So the pharyngeal tonsil sits in the pharyngeal recess. I haven't seen many tonsils on the cadavers, but if there was one, it would kind of look like little bumpily type of, almost like the back of the tongue looks up in here. Should have some substance to it. That would be what the tonsil would look like. But in general, if we're just talking about this space right above torus tubarius, that's the pharyngeal recess. Okay guys, now let's move on to laryngopharynx and larynx. It's easier from this view, so let's get going with that. First, I just want to help orient you. This may be how you see it on the practical. However, remember that sometimes we actually take one whole half off the body, completely disconnect it. So you may actually see all of this split and only one half laying here. Some of the structures are still fair game, so practice during open lab seeing different things. But at this point, so we're looking at, this is the laryngopharynx in here, just posterior to the larynx, which is pretty much from the epiglottis down. Esophagus is down here. You see these nice little bumps here. These are the superior horns of the thyroid cartilage. And if I closed everything up again here, then we would have the pharyngeal constrictors, specifically inferior pharyngeal constrictor down here. So now it's all opened up. And we can see laryngopharynx and epiglottis. So let's get going, but really make sure in a practical situation you orient yourself. So if I tag this here, even though it's split a little bit, this is a fair tag, so let's just identify. So this is our median glossoepiglottic fold. And now I wanted to think really carefully about how I said that, because I could have easily said ligament. However, I have not removed the mucosa from the back of the epiglottis here. So mucosa is still intact, it would be fold at that point. And if you can imagine everything being put back together here, you can see that our tongue would be here, and what I'm tagging is coming out midline from the back of the tongue to the epiglottis. So use the name to help you, glossoepiglottic ligament, and median because it's right in the middle. On either side, I have the lateral glossoepiglottic ligaments, which are also fair. And of course, because the mucosa is still intact, if I pinned either one of these right here, they would be the lateral glossoepiglottic folds. So now let's move on to this. So what are my scissors going through? If I do something like this on the practical, what I'm most likely going for is the laryngeal inlet or additus. Either way is fine. But because everything is still intact in here, and I haven't split this all open, which I will do in a little bit, my scissors are going straight through the laryngeal inlet or additus. How about if I tag that? And let's make it a little bit more interesting and say identify function. So first, let's identify the structure. In your mind, you're going to say that this is the posterior cricoarytenoid muscle. We can see really nice fibers traveling out laterally. We know that we're on the posterior aspect of the larynx. And these big sweeping fibers on the back of the cricoid cartilage, which is right underneath here, sweeping out laterally, has to be the posterior cricoarytenoid muscle. So identify function. This would be important because the posterior cricoarytenoid muscle is the only muscle of the larynx that abducts the vocal ligaments. Abducts, abduction, meaning pulling them farther apart. So here it is on this side, and here it is on this side, sweeping laterally to attach on the muscular process of the arytenoid cartilage, which is kind of deep in here and over here on this side. So this is that big posterior lamina of the cricoid cartilage. Remember that the cricoid cartilage is much thicker and bigger posteriorly than it is anteriorly. We only see a little, like half a centimeter bit of it anteriorly, but here we see the nice big posterior lamina. This is why it's called that signet ring shaped cartilage. And remember that it is a full ring. Now let's look at a very delicate structure right there. Let's just identify. So this is maybe a little tricky, but if you get in there really close, you can see that I'm grabbing a little bundle of fibers. If you follow them out this way, you can see that they connect up to, or they go up and run obliquely into this next structure that we'll talk about. So this is the oblique arytenoid muscle. You can see its kind of brother on this side right here, running similarly, crossing with it in the middle, going this way like this. So here's one on this side, and here's one on this side. Now if I pull this aside and pin something a little deeper underneath there, kind of hard to see, but if you get in really close, you can tell that there's a different fiber direction. Now I'm asking for transverse arytenoid muscle. So the oblique arytenoids cross superficial to the transverse arytenoid muscle, which is underneath here and has a transversely oriented muscle fiber. Awesome. So before we move on from this area, as I put my finger in here, I can pinch this lateral wall of the laryngeal inlet like this with my fingers, or on this side right here. I know that might be hard to see, so let me use my forceps. So I'm pinching right here, or I'm pinching right here. Specifically over here, where I hope you can see in the video that there's still mucosa covering all of this, whereas on this side there isn't. So if I pinch that there and ask identify, you guys are gonna say the quadrangular membrane. So with mucosa still on it, kind of supporting that opening, that laryngeal inlet, is your quadrangular membrane. Now on this side where I've removed a lot of the mucosa, you can see some pretty cool things. Right here, underneath the mucosa that makes this bump right here, is the cuneiform cartilage. You can barely see, but see how there's a bump here with mucosa on it. So if you take the mucosa off, you're left with the cuneiform cartilage. The function of that is to just support the laryngeal inlet. And then there's another bump right here with mucosa on it. If I take that mucosa off, I'm left with this little kind of curly piece of cartilage. This is actually the corniculate cartilage that sits on top of the arytenoid cartilage, which you can see underneath there. Right there. So corniculate is a little hat sitting on top of the arytenoid cartilage right there. Okay guys, let's identify this structure. So this is our favorite little internal branch of superior laryngeal nerve. And the reason why you know that is because on either side of the epiglottis here, just a little inferior to it, you see these big divots, these big pockets. These are our piriform recesses, and the famous nerve going right through the piriform recess is the internal branch of superior laryngeal nerve. Moving on down a little bit, we see two nerves on either side. Really nice on either side. Let's identify this. So in this situation, it would be really hard not to say recurrent laryngeal nerve, because technically it is the recurrent laryngeal nerve. However, we are inside the larynx now. So it gets a new name. Now both of these are called the inferior laryngeal nerves. And they go through a gap, so it would be important to remember what gap they go through. It happens to be gap number 4 between the esophagus, which is way down here, and the inferior constrictor, which ends right about here. These guys come right through, and remember, once they're through that gap, they get a new name. They're now inferior laryngeal nerves. Still part of the vagus, still from cranial nerve 10. So there are a couple other laryngeal muscles that you can't see from this view. Remember in dissection when you guys took out half of the thyroid cartilage, you took out one lamina of the thyroid cartilage. on the more anterior aspect of the neck. I didn't happen to do that because I didn't want to destroy some things, but make sure you find one of us during an open lab and we'll check out some of the bodies where they did take out the part of the thyroid cartilage. Underneath that lamina of the thyroid cartilage, you should find the other two muscles, the lateral cricoarytenoid and the thyroarytenoid muscles. Okay guys, so now we're looking at a slightly different view. You can see, compared to the last picture, I've split the posterior lamina of the cricoid cartilage, and now we're looking inside the larynx. So there's two structures that are kind of hard to tag here for the video, so I'm going to go through them quick and then we'll go to some other structures in here. First, what my silver probe is wrapped around, you guys should be able to identify that as the, you got it, the true vocal ligament. So hopefully you can tell that I've removed mucosa. Hopefully you can tell by looking at the other side. The other true ligament has mucosa on it. This one does not. So even if you can't see it in the video, just make sure when you take a closer look in the practical situation that you can get close in there and see that I'm looking at more of a white or a cream colored ligament without mucosa on it. And then what I'm holding here with my forceps, that the green colored pin is tagging, is vocalis muscle. So these are the most medial fibers of the thyroarytenoid muscle that we see when we remove the thyroid cartilage lamina. So the most medial fibers of that muscle are specifically named vocalis, and remember they're responsible for fine tuning, like when you're singing or talking. So these are probably the deepest, more specific structures that we could go after in the larynx. Okay guys, so taking another look at the internal portion of the larynx, we see epiglottis here. We've turned everything a little bit so that you can see it better on the camera, on the video, but let's identify this structure here. So clearly we can see there's a little divot right here, there's a ridge here, and a ridge here. So if I ask you this ridge, you're going to say that it's the vestibular fold or false vocal fold. This divot in between the two is the laryngeal ventricle that holds all of the mucus to keep everything lubricated. And finally, this structure here is the true vocal fold or just true fold. Based on the previous picture that I showed you with the mucosa removed, here hopefully you can see a little bit better that the mucosa is intact and we're looking at folds instead of ligaments. Okay guys, now we're heading into the infamous pterygopalatine fossa area. I know this area seems really daunting and really scary because everything inside it is really small and you basically can't see it, but I did my best to try and pull out everything. We might use either side because Ashley did an awesome job too. So just bear with us with the camera. We're gonna try and make everything look as good as possible, but of course these things are pretty tiny. So as far as tackling this area, I would just go through the checklist on as many cadaver bodies as possible, keeping in mind that some things are going to be intact and some aren't. Dr. Buck will have his head set up with a lot of these structures that you need to know, and you have plenty of time to get it down. So let's get started. Remember to orient yourself. So first thing I would notice when coming up on this tag is that I'm obviously looking at a mid-sagittal section, and right away I can see I have a big hole in my lateral nasal wall, so I'm looking into the maxillary sinus, and I can see these two main structures coming down like this to the palate. So use what you know and use what we did in dissection to help you find the things that you're looking at. Let's identify this structure first. So this is our greater palatine nerve. I know that because I see two things almost like legs coming down to the area of the palate. One is much bigger and one is much smaller. In dissection, we chipped through the bone in this area to find these guys first because they are usually the easiest to find and they lead you right to where you need to go. So if I have a string or a pin in these right here, I'm going to call it the greater palatine nerve, and I can follow it all the way down here to the top of the palate, going out to the hard palate. Similarly, this smaller guy, just like a leg coming off of the pterygopalatine fossa, going through the pterygopalatine canal or the floor of the pterygopalatine fossa. This is our lesser palatine nerve coming all the way down and going out back to the soft palate. So if I move either of these guys aside, I have some structures back here. Let's identify this one. Let me get it from this angle instead. So this is our lesser palatine artery. Sometimes these two can be harder to tell because you never really know when the lesser and greater palatine arteries are going to split off of the descending palatine artery. So let me show you in this specimen how it works. So I'm moving aside greater palatine nerve and I see this big artery back here. Maybe if I move it this side it might be easier. So up here there's just one artery. At this point I'm going to call it descending palatine artery. As I come down this way, and you can see how tortuous these arteries are, they can sometimes trick you, but down here it splits into two. I see one on this side and one on this side, and especially as I move down further you can see how that is clearly separate from this bigger guy over here. Sometimes the split occurs farther down here, sometimes up here, so really just follow the structures with your eyes. We should give you enough room to see exactly what you need to see to identify it correctly. So right here we notice there's a cut structure. This is how we will see it in the practical situation because this artery should be cut. It's the one emerging from the sphenopalatine foramen to supply the lateral nasal wall, kind of like a branch, like this branch here that comes out to the inferior concha. So if you see a little nub of a cut artery here, you're going to call it the sphenopalatine artery. Emerging through the sphenopalatine foramen. This was one of those first structures that we saw during dissection when we were pulling all the mucosa off of this area. Still, all the bone in here was intact. We saw this little guy emerging, coming out to the concha. We followed it back in to get us into this area. So, cut little nub of an artery, sphenopalatine artery. We pull these guys kind of aside, we immediately see this little tiny artery coming out here. Let's identify that. This is going to be the pharyngeal artery. And we know that because from Dr. Funk's lecture, it's really important to remember that there's three main structures that run this direction in the pterygopalatine fossa. And they always run from medial to lateral, pharyngeal, pterygoid, and then V2. So at this point, I'm as medial as I can be. There's nothing else more medial to this structure. Therefore, I know this is either going to be the pharyngeal artery or the pharyngeal nerve. And so when I pull up this system of arteries, I can clearly see that it's connecting to the arteries. That's how I know it has to be the pharyngeal artery or artery of the pharyngeal canal. Either one is good. When I move this aside, I see a tiny little nerve resting right next to it. This then has to be the nerve of the pharyngeal canal. If I now pull all of these arteries aside and I'm following my my greater and lesser palatine nerves more superior, and I follow the nerve we just identified, the little pharyngeal nerve, to this dilation right here. Let me give you a little bit better view. So I know it's going to be really hard to see, but where all these nerves meet and come together is at the pterygopalatine ganglion. And more likely than not, we would put a pin right in it. So right where you can see greater and lesser palatine nerves come up, you can see this pharyngeal nerve meet back here, and it looks almost like a little dilation, a little circle with a pin in it. Gotta be the pterygopalatine ganglion. As we look out from the pterygopalatine ganglion, you can see deep in there, laying right underneath my probe, is a structure that extends all the way out, headed towards the orbit. This is your infraorbital nerve, or V2, the connection or the continuation of V2. So I could wrap a string right around there, or put a pin in it, and that would be V2 or infraorbital. So here was our ganglion. What if I tag that structure right there? So clearly we can see that it's connecting the ganglion to infraorbital nerve, or V2. That must be then those little suspensory arms connecting the ganglion to V2. We call those the pterygopalatine nerves. And there might be the other, there should be two of them. There might be another one right there, but it's a little harder to dig out. So sometimes there's two, but here you can definitely see one. One of the other extremely small structures in this area that's very hard to see sometimes are these guys right here. Bear with me for a second. So there's one, and there's the other, and they connect here and run together just lateral to these two structures that we identified. I could separate them, but I would be really scared that I would break them, so I'm not going to. However, in a practical situation, they would most likely be separated for you. One is the the pterygoid artery, and the other is the nerve to pterygoid canal. So really just follow them with your eyes, see where they're going. One should connect back to the arterial system, one should connect back to the pterygopalatine ganglion. That will tell you exactly what they are. So now as I continue to look forward, so I know it's really deep in there. On a practical situation, don't worry, you would be able to get in there and really get a good look. But you'll notice when you get in there and look that it's an artery traveling out the same direction as the infraorbital nerve. Therefore, you would definitely call it the infraorbital artery. Okay guys, we switched to the other side of the cadaver head here for the last couple of structures because they're easier to see. So again, orient yourself. Know that we're looking at the lateral nasal wall here that has been cut away, and now we're inside the maxillary sinus. Immediately, you should see one main structure going right through the top of the maxillary sinus. So this is V2, or infraorbital nerve. Remember in Dr. Funk's lecture, she talked about how it's only technically infraorbital nerve once the zygomatic branch comes off. We were unable to find it in this dissection, but that's important to remember. If you guys can see that in any of your dissections or in the open lab, that's really good to look for. But in any case, this is infraorbital nerve connecting out here to the orbit. Right away we see this structure branching off of it. Just identify, so this would be the posterior superior alveolar nerve. The first branch that we see coming off of infraorbital nerve, branching and going straight down to the upper teeth, or the superior teeth, the maxillary teeth, posterior superior alveolar nerve. Then as we follow infraorbital out even farther, we see another branch coming down. This would be middle superior alveolar nerve. So posterior, middle, and then the last one we would see is anterior. And in order to show you that, I really have to turn the cadaver. And you can really just see this one traveling straight through the bone. I know the view might not be great. If you can't really tell, just make sure you grab us an open lab and we can try and show you a better one. But you should be able to see these three nerves traveling through the bone, or they may have been removed from the bone. Just like that, posterior, middle, and then anterior alveolar, superior alveolar nerves. Okay guys, so we're looking at the same view that we just were, and you can see that there's a pin here, but in order for you to really get a good view, I have to turn the cadaver kind of like this. So now you should be able to see that the pin is in an artery, but it's really deep in there. Let's try and identify this. And don't worry if you don't know what it is, I'll try and walk you through it. So this is the third portion of the maxillary artery. I know it's really deep in there, but there are some really good clues to help you out with this one. First of all, we see that it's kind of coiled up in here and that it sends off all these little branches. One of them we can see coming out straight like this, and it's cut. So the fact that it's cut and it's coming straight out towards the nasal cavity is the biggest clue that this is your sphenopalatine artery. Then we can see as it coils around here, one comes down like this. That would be descending palatine, eventually splitting like we talked about before. And now as I pull this out even farther, you can see one branch goes straight out with infraorbital nerve. That must be the infraorbital artery. And those are some of the most important branches off the third portion of maxillary artery. So as you can see, it's coiled up in here. Those branches tell you for sure that that's the third portion of the maxillary artery. Okay guys, so I just wanted to give you one last thing to take home. This is another view of a pterygopalatine ganglion with a pin in it on the other side of the cadaver. Just wanted to give you as many views as possible because they tend to look a little different from cadaver to cadaver, and even from one half of the head to the other half. Some really great second or even third order questions regarding the pterygopalatine or pterygopalatine ganglion, or even this area as a whole, would be to ask what kind of cell bodies live here, what fibers are traveling through certain nerves, how certain nerves get to their ending structures. So for instance, if I pinned the pterygopalatine ganglion right here, like you see, and asked what cell bodies lie here, you would want to say postganglionic parasympathetic cell bodies. So this is how we get parasympathetics, specifically GVEP fibers, to such things like the lacrimal gland. They synapse here, and the postganglionics get to the lacrimal gland from this ganglion. Also the paranasal sinuses, all the mucus glands there, all the mucus glands in the palate, and all the mucus glands in the lateral nasal wall. All of those structures receive parasympathetics, specifically postganglionic parasympathetics, from the pterygopalatine ganglion. And since we have parasympathetic fibers going to all of these structures, we also need sympathetics to kind of balance everything out. If you remember from Dr. Funk's lecture, the sympathetics gain access to these areas by jumping on with the exact same nerves, usually from branches of V2 that just spread out to all of these structures in this area. But specifically from the internal carotid nerve that creates the little sympathetic plexus on top of the internal carotid artery, there's a little nerve called the deep petrosal nerve that supplies sympathetics to this area. So that deep petrosal nerve joins with the greater petrosal nerve, which carries just parasympathetics. They join together to become the nerve to pterygoid canal, that one that I showed you on the other side. So that's specifically how the sympathetics get to these areas. They don't synapse in the ganglion, they simply pass through it to spread out via branches of V2 and supply all of those areas I just mentioned. So it's really important to think about some second order or even third order questions that we could ask you, and those might be some of the tougher ones. But remember too, that material will be fair game for your written test that's still coming up as well. Okay, guys, thank you so much for watching. We really hope that you benefited from watching these. If you didn't watch Ashley's video yet, we really want to encourage you to, because it has the other half of the checklist that I did not go over. And it's really great because she's really awesome. So please let us know if we can clarify anything for you. Come find us in open lab or stop by the office anytime. And let us know if you have any feedback as well. Thanks again, guys. Good luck. You're going to rock it.